So the aim of the lecture is, of course, to get insight in the management of some common and less common ERCP and EUS related challenges. And I think that ERCP can be brought back to 3 challenges I can get in. And so we will cover here difficult selective cannulation, difficult passage of strictures. I can get it out. So we will not cover difficult stone extraction because this would need a whole session, but we will cover difficult stent extraction. And I'm in serious troubles. And this is related, of course, to complications. And we will also cover ERCP-related perforations and how to recognize and how to manage them. I will give the word now to my colleague Helena de Grote, who will cover the first topic.
So we start with a case of a difficult biliary cannulation. It's a 65-year-old patient post-liver transplantation, not so long ago. He had cholestatic liver tests, and on the MRCP, it was not a problem at the anastomosis, but an ischemic cholangiopathie with bilateral subhilar stenosis. As you can see here, the MRCP image, it looks difficult already like this. It was his first ERCP, so we first had to do the cannulation. We started, of course, with a standard guide wire. Then we exchanged already several guide wires, but we still couldn't get in the papilla. So the next video is how we proceeded. So we had to do a pre-cut fistulotomy to get in this papilla. You can see here that we aim for the direction of the bile duct at 11 o'clock. So we have to go deeper. You see already bile flowing. And after this fistulotomy, we proceeded with the guide wire to try to get in the bile duct. But as you can see here, we first had a wire in the pancreatic duct. So we had to do the double wire technique with a second wire. And you can see here the direction. It has to be in the right direction looking at the pancreatic duct. And then we could get in the bile duct. So we had to perform 2 techniques to get in the bile duct.
So the guy that's training with me at the moment already has done 1 year. And so, you know, he can do pre-cut. Mm-hmm. Basically, I don't have to do any ERCP, which I'm very happy because I have enough to do. But, yeah, so you need a lot of training. And in Australia, the guidelines are you have to have done 200 naive cannulations, successful. So these are quite stringent. So that means you will not get to 200 naive cannulations without having done 600 naives. If you're learning.
So you need definitely more than 1 year, I would say as well,
But I guess the bottom line is quality over quantity.
Yeah, I think ERCP now, it needs to be somewhat centralised. You know, you can't have a centre that does 2 a week. Or
That's where we might be going, but it's we did it also in Belgium. It was done with pancreatic surgery.
Yeah.
Now it's centralised. But it's a bit more.
How long has it been centralised, pancreatic surgery?
It's recent. It's
3 years.
3 years.
3 years.
But I bet you that'll be a New England Journal publication if they follow the data, because the outcomes will be so much better.
Oh yeah, they saw the outcomes. We had the curve. You see the curves about the different the mortality rates. Benchmarking was like 5%. You had to have your mortality rates, and then you had centers that were like 20%. And that's when they decided that we have to centralize pancreatic surgery. So that was something that was easy to apply because it's at one point you understand that you don't want to do some pancreatic surgery just to do it through a year, but you have to put a lot of other implementation to have the reimbursement. But the ERCP will be politically more difficult.
Will be more difficult.
Is that often still the case that you reschedule it, or do you proceed directly to echoendoscopy guided therapies?
That's also a very good question. I think that if you have to think about the patient first and why you're draining this patient and what are the consequences if you cannot do the biliary drainage. But if the patient has no cholangitis and if you really are blocked, I think it's better to refrain and reschedule with some, maybe a colleague with more experience, or refer the patient, than do something that you're not controlling and that might be dangerous. So I think that we have to think about the indication, not just say, okay, I have to drain this papilla because I have to get in.
Yeah. And you see some quite high success with repeat ERCP. So Peter, can you comment? We also did a study.
So this is because rendezvous, it's very rare, so we don't do it very often, but so it's about 1.8% of the ERCP patients where we can really not cannulate the bile duct even with pre-cutting. And so starting from March 2018, we have been performing EUS guided rendezvous, and we compared it with a historical cohort. It's all retrospective, of course, but it's just because these patients, we don't have them very often. And we compared the outcome of the patient with PTC guided rendezvous. So we did this together with interventional radiologists. We looked at technical success rate and complication rate. Yes, next please. So in fact, patient characteristics, so in terms of age and sex and performance status, it was quite similar. Type of biliary disease, we had some more malignant disease in the EUS rendezvous as compared to the PTC rendezvous. Yes? And if you look at technical success rate, so you see that PTC rendezvous had a higher technical success rate, about 90%, where we had 72% in the EUS rendezvous. But this also included, unfortunately, the learning curve of the procedure. If you looked at complication rate, and these are really all the different complications, it was quite similar. And if you look at major complications, this was tended to be higher in the PTC rendezvous group, while in the EUS rendezvous group, it was mainly related to pancreatitis, because we often do it in one procedure after failed cannulation. Okay, next. So it has definitely a learning curve.
You can get different guide wires that you can...
025 Visi sometimes will just kick it across for you. Yeah.
Torquing helps as well.
Yeah, sometimes we also break it. We break the guide wire a bit more, we give it an extra 90 degrees with the pin.
But also flexing the sphincter drum helps.
You can put you can so for this side, right, the sphincter tone naturally goes like that. So you ask your assistant to stand 3 meters away from you, and you make everything straight.
Yeah.
And believe it or not, if you put the sphincter tone down backwards, it comes out backwards. And then if everything's straight before you put it in, and it will come out backwards for you, and then you can
have a different
tighten and get a different angle.
Yeah.
Yeah.
I've learned something today.